to the next talk on how can India be prepared for the third wave and transplantation. May I invite the speaker, Dr. Sandeep Guleria. I now invite the chairpersons for this talk, Dr. M. Bahadur, Dr. Sanjeev Jasuja, and Dr. Mohammad Iqbal. Over to the chairpersons.
Hi everybody. Last 1.5 years, we have been going through the pandemic, and we have now learned to live with it. Not really to live with it. As transplant specialists, we have started to do transplants also, to coexist and do transplants in the era of COVID. So, will there be a third wave? How are we going to deal with it? Are we better off in dealing with more sinister sort of viruses that are going to come? If so, over to our great professor, Padma Shri Sandeep Guleria. Over to sir.
Yeah, I'd like to thank the organizers and for inviting me to give this talk on how India can be prepared for the third wave. And I shall spend briefly the next 10 minutes on first giving you a background of the first wave, the second wave, what we learned, and how we can use this for the third wave. So if you look at the total effect of the COVID-19 pandemic, this is the effect that occurs from weeks to months to years. The first is that you have an acute COVID infection, which occurs for weeks to months. Then you have a delay in urgent care, lack of guidelines. You have repetitive COVID infections. You have patients who get neglected chronic conditions, require long-term acute care. And finally, you have patients who require mental health and economic burden, which continues for a very long time. This is the effect of the pandemic on global health. So it just didn't affect people who got COVID or transplants, it affected everybody. There were 1.4 million additional deaths by 2025 of tuberculosis. There were 673 additional HIV-related deaths. There were 382,000 deaths because of malaria. Lots of people missed out their immunization, non-communicable diseases got missed out, reproductive health suffered, and this has been the deepest global recession since World War II for the world. There was, of course, if we come back to transplantation, a steep reduction in organ transplantation. There was a 51.1% reduction in deceased organ transplantation. A 71.8% of centers placed complete suspension of living donors transplantation, and 84% of transplant centers added restrictions to what they were doing before the pandemic. So the impact of the COVID pandemic unfolds in three waves in solid organ transplants. The first wave is that it delayed elective procedures. Routine patient follow-up was delayed. The second was that you had a huge wait list that dropped out, people died. And finally, you had a number of patients who missed follow-up, became non-compliant, you couldn't screen them well, and they ultimately couldn't even get their medicines, and you lost them to progressive disease. This is the effect of COVID that COVID had. This is the first wave on the transplant wait list. And as you can see, COVID-19 had a dramatic impact on waitlisted patients. If you look at waitlisted patients, 82% of them got hospitalized, 34% mortality as compared to 16% who underwent a transplant, and 29% of them had a poor prognosis. This is the impact of the slide on surgical services. And as you can see, the number of surgical cases got delayed. Initially, you had to suppress it. Only emergencies were done. When the deaths became less and ICU beds became available, we could gradually restart our transplant services. And gradually, of course, daycare, outpatient clinics, and transplants started. So what was the difference between the first wave and the second wave, and what did we learn? So in the first wave, there were national lockdowns, which didn't happen in the second wave, right? There were resource limitations that didn't happen in the first wave. That was there in the first wave, but not in the second. There were far more hospitals, better equipped, more ICU beds, more PPE kits, more RT-PCR testing. There was no quarantine now for healthcare workers. There were teleconsults had now become a part in the second wave. You had home quarantine was done for asymptomatic cases. Hydroxychloroquine, azithromycin, convalescent plasma that were very common in the first wave were replaced by remdesivir and steroids. HRCT thorax was used only in moderate cases. We were not admitting everybody who tested positive. And the choice of steroids changed from methylprednisolone to dexamethasone. Also, the inflammatory markers were not repeated very frequently, and the criteria for hospital discharge also changed between the first wave and the second wave. This is the daily new confirmed cases in from March 1 till date. And this, as you can see, per 1,000 cases, the highest number of patients were seen in the United Kingdom, followed by the United States. If you see India, this is what India did. We were sailing along quite well till April and May when we had a second wave, and currently we seem to be fairly well controlled as far as COVID is concerned. If you look at a systemic review and the meta-analysis of COVID-19 in kidney transplant recipients, what we learned was that the risk of mortality and acute kidney injury is high among our recipients and regardless of sex, age, and comorbidities. And we learned that we must vaccinate our patients, get them to have a high anti-SARS IgG COVID antibody if we could, and that would be the best way to make sure that COVID impacted us less. So the lessons that we learned was continuation of current immunosuppression with calcineurin inhibitors and prednisolone, decrease the antimetabolite. The other thing was the use of monoclonal neutralizing antibodies, which are currently available, and we've used that in a few of our patients. Continuing of immunosuppression with calcineurin inhibitor treatment if they had moderate with a 25 to 50% reduction, giving dexamethasone and holding the MMF in patients who were admitted. And then, of course, severe patients only requiring intensive care, we were actually holding all the immunosuppressants, only giving them steroids. If you look at the global response and the response of kidney transplant centers, the kidney transplant recipients, what we learned was, could be effectively managed in a time of crisis with appropriate accommodation and measures in the vast majority of cases. And in the second wave, we learned that it was easy to use remdesivir and sometimes tocilizumab in these patients. This is the data that came from the Eastern European perspective, which compared the first and the second wave. And what it concluded was that most patients' characteristics and outcomes were comparable between the COVID-19 waves. Most kidney transplant patients were managed as outpatients without an overall negative impact on their survivals. This is an article that came from the Indian Transplant Center. Again, we found the same results, different clinical spectrum among kidney transplant recipients with similar mortality between the two waves at a large Indian transplant center. So what are the lessons that we learned now from these two waves? The first lesson we learned was that deceased and living donor transplant activity has to be assessed by each center on the basis of the severity at their region. Once RT-PCR should be done within 3 days, and a second should be done 24 hours before admission. For donors who had COVID, we were advised to wait for 21 and 90 days, irrespective of the NAT results. We could do a chest CT scan if patients were positive or had chest symptoms. Consideration should be given towards lower cold ischemia time. And if donors had had COVID, we must wait for 30 days. And of course, we must always emphasize the value of vaccination for COVID-19 before transplantation. What did we learn from the recipient? Patients aged more than 65, especially if they have additional comorbidities such as CVAs, diabetes mellitus, we could push back transplantation for some time. Transplantation in patients who are highly sensitized with the use of ATG or rituximab should be assessed patient by patient, considering the severity of pandemic in the region. And for recipients who've had COVID-19, we learned to wait at least 30 days before we took them up for transplantation. And of course, ideally learned to vaccinate them all before transplantation. The other thing that came up sometime when the second wave was at its peak or just about to decline was the antibody cocktail drug, which was very helpful in patients who actually got in an early stage of mild to moderate COVID. And this was a cocktail of casirivimab and imdivimab. I'll just share some data for this. It is to date the only therapeutic agent for COVID-19 in the ambulatory setting And these are neutralizing monoclonal antibodies directed towards the SARS-CoV-2 spike protein, right? Currently, the only one that is used is this of casirivimab and endivimab. They are both available in India. We have used them on 2 patients. I know a few liver transplant patients who've also got that early and have done extremely well with this. For the treatment of COVID-19 in patients aged 12 years and older, the risk factors that may include, this is what you could do if you have an advanced age, obesity, CKD, chronic cardiovascular disease, diabetes, chronic liver disease, or immunosuppressed patients based on the prescriber's assessment. So if your patient fits into this, where most of our patients would fit in, this monoclonal antibody in mild to moderate COVID could be a life game changer. If you look at, is it safe for transplant patients? We don't have too much data, but whatever data we have comes from an open forum infectious diseases, which says that if you use this, no patients required mechanical ventilation, died, or experienced organ rejection. Monoclonal antibody therapy is really important for the transplant population because they're less likely to develop their own immunity. Providing them with these antibodies helps them recover from COVID-19. Just a few publications. This was the first publication on monoclonal antibody therapy for COVID-19, which said it has favorable outcomes with minimum adverse effects. There's another one, which is in ahead of print, which said that had 25 solid organ transplants, none experienced progression of symptoms or required hospitalization. The recommended dose is about 1200 milligrams of casirivimab and 1200 milligrams of imdivimab. It comes as an IV infusion, and the rate of infusion can be slowed if the patient develops any symptoms. Finally, to what has been the biggest changer between the first, second, and hopefully a third wave is vaccination. This is the share of people vaccinated against COVID-19 as far as September 21st is concerned. And if you look at India, we've done reasonably well. 44% of our population is vaccinated, and about 15 to 20% is fully vaccinated. This is great news for a country that has a population as large as India, which still is struggling, which was struggling with healthcare and with its healthcare resources. So I think we've done reasonably well as far as vaccination are concerned. We may not yet be on target for vaccinate everybody by the end of this year, but we seem to be well on its way. Basically, the rules and timings of vaccination against COVID-19 remain the same. All candidates on a waiting list should be vaccinated. Patients after transplant should be vaccinated if there are no strong contraindications. COVID-19 vaccination of patients early after transplant with standard immunosuppression should be deferred for 3 to 6 months. COVID-19 vaccinations early after transplant, which consists of rituximab or ATG, should be deferred for 3 to 6 months. After treatment of acute rejection, you should postpone vaccination for about a month. Patients who get rituximab, again, give them the vaccination after 6 months. mRNA vaccines are not considered to increase the risk of acute rejection. Patients with atypical HUS and kidney transplants and eculizumab should be vaccinated. And there is a lack of recommendations for vector-based vaccines. However, the ASTS underlines that up to now, they have not recommended live viral vaccines for transplant patients. So this is as far as waves go. As far as the first wave came, it was accompanied by shock and fear that leads to careful and follow all advisories that helps break the chain. However, since everything is new, tackling the first wave takes long. By the time the second wave comes, the virus has mutated. The second wave is nastier, but society is better equipped, the learning of the first wave, and manages to control the second wave faster. As a third wave comes, or should it come, a large number of people are vaccinated, have acquired natural immunity, and it should be the smallest and the weakest of all the 3 waves. Will there be a third COVID-19 wave? This is a model which came from the IIT Allahabad, as well as the SRM Institute of Science and Technology. And they said that they have studied India and 8 Indian states with varying SARS-CoV-2 infection. And they feel that from time to time, its intensity will slow down with time. In most possible situations, our calculation shows that COVID-19 will remain an endemic for foreseeable future, but it will slow down and we should continue to vaccinate a large number of people. So how can be India prepared for the third wave? We must collect, share, and use data to drive interventions. We must continue to sustain surveillance, accelerate vaccinations, stepping up non-pharmacological interventions, make sure that lives and livelihoods are important, allocation and management of resources, communication, using technology like we use drones to deliver the vaccines, managing mental health, and post-COVID care and rehabilitation. So I think we are more or less prepared as far as the third wave goes. I don't think it's going to be as strong as the first or the second wave. And I think vaccination is going to be a big game changer. So kidney transplant in the COVID era, cautious optimism and continuous vigilance, vaccination of all patients who are on CKD or are waitlisted, strategies that enable transplant practice to resume, including widespread use of teleconsults and pre-surgical training, pre-surgical screening. Although grounded in science, the field of transplantation has always incorporated elements of art, experience, theory, and preference. And putting aside the jargon of classical medical ethics, the global response reflects the straightforward principles of doing the right thing for our patients at the right time for the right reasons. And finally, of course, whether it is the first, the second, or the third wave, the soul of transplantation just cannot die. Thank you very much for your attention.
Thank you very much, Professor Guleria. That was a extensively covering and interesting topic. I would like to have a query. Professor Guleria, have you ever had a chance to reusing this monoclonal antibodies, like in the second infection or reinfection, sort of? Do you advise?
I have not had the chance to use it. Unfortunately, I have not had the chance. I've only used it in about 4 patients, but all 4 have done very well. And I think it's going to be a game changer. But I have not reused it. I know the liver transplant team have used it in 2 patients and they've got away with it as well. Both their patients survived. So, you know, whenever we have a patient now who we think is got very mild, who's not doing well with our initial steroid, upping the steroids and taking off the MMF, we would now think of using a monoclonal antibodies.
That's great. Dr. Bahadur, do you want to add to anything or any?
Yeah, I think I agree with the professor. Absolutely, we have been using this monoclonal antibodies in not as outdoor patients, and actually patients are indoor. Right now, we have a patient, and it is a game changer. I agree completely with Professor Sandeep. It is a game changer, and what is also really adding on is the vaccination. I think these 2 things will change the way how transplants would behave in the future. And Professor Guleria, you have really summarized it very well. What to expect, because we really didn't know what to do with this third wave. But I think you've really done an excellent job on this.
Dr. Sanjeev. One thing I always encounter is this comes in a dual pack. Can split into 2 patients. I always wonder why we can't give the whole thing to 1 patient. Will it make any change, or is it any side effects if you give a overdosage like that, all the whole thing to the single patient? Do you have anyone has an opinion about that?
So I'm not really, we get it from a hospital pharmacy. So we only get the dose that's 1200 milligrams of one and 600 of the other. I'm unaware of this really, because we just write it down and it gets dispensed.
So initially the dose prescription was 1200 for each.
Yeah.
It later changed to 600. So that is why the pack comes as 1200, but 600 of each is fine. So we actually go on wasting 60,000 unless we have somebody else to give to. So that's what we try to do. However, in a transplant patient, it doesn't matter, even if it goes waste.
Absolutely. Excellent. That was great. That was a great topic. Thank you, co-chairs, and thank you very much for the organizers for giving us the chance to chair this session. Thank you. Thank you, ISOT team, Cochin.
Thank you very much, sir.
Thank you, speakers and the chairpersons, for that wonderful session.